Imagine knocking down a major load-bearing wall in the center of your house, clearing out all the debris, and then, expecting the roof to hold itself up perfectly the very next morning.
Right, you would never do that.
You'd never do it. You have to install steel beams, let the new concrete foundation cure for weeks, completely reroute the plumbing before you even think about repainting.
Exactly.
And yet, when we talk about a major internal surgery like a hysterectomy, we have this bizarre cultural expectation that the human body should just, well, bounce back almost immediately.
It's a massive biological disconnect. We intuitively understand that a fractured femur takes months to calcify and bear weight again, right?
Oh, totally.
But with the removal of internal organs, especially if the external incisions are tiny, like in a laparoscopic procedure,
Yeah.
or entirely invisible if it's done vaginally, we just drastically underestimate the staggering biological engineering happening inside you.
Which is incredibly dangerous. And for you, the learner listening to this deep dive, that hidden reconstruction site is exactly what we are exploring today.
Yeah, we've got a really complex stack of sources for this one.
We do. We are pulling from clinical guidelines from major medical bodies like NICE, that's the National Institute for Health and Care Excellence, and the NHS. Plus, we're looking at comprehensive post-operative care manuals alongside some pretty cutting-edge and hotly debated research on cosmetic gynecology and vaginal laser therapies.
Because the landscape we're navigating today, it really tries to balance the absolute necessities of medical recovery with the deeply human desire to, feel functionally normal again after a major bodily trauma.
Right. And our mission today is to answer one specific, crucial question drawn directly from these sources. How long after a hysterectomy should I wait before vaginal tightening?
Which is such a common question.
It is. But before we can even touch the concept of lasers or radiofrequency or cosmetic tightening, we have to look at the structural foundation.
We need to dissect the massive internal reconstruction project your body's undertaking right now.
Yeah, and figure out whether tightening is even the actual solution to the symptoms you might be experiencing.
Exactly. Because we simply cannot discuss altering the vaginal canal without mapping out what is actively healing inside you first.
So let's talk about that surgery.
Right. So when a surgeon performs a total or radical hysterectomy, they're removing the uterus and the cervix.
And the cervix is basically the bottom anchor, right?
Yeah, it's the anchor of the uterus, and it connects directly to the top of the vaginal canal.
So once the uterus and the cervix are removed, you're just left with an open tube at the top of the vagina.
Yes, which means the abdominal cavity would just be exposed.
Wow.
So the surgeon has to physically close that opening. They pull the top edges of the vaginal walls together and suture them tightly to create a biological seal.
Okay.
And medically, this is known as the vaginal cuff.
The vaginal cuff. I kind of picture that like the sewn seam at the very toe of a sock.
Oh, that's a good way to look at it.
Like you've removed the foot, which in this case is the uterus and cervix, and now you have to stitch the end of the fabric closed so the tube isn't just wide open.
That visual is perfectly accurate. And that seam, that vaginal cuff, it becomes the absolute epicenter of your entire recovery process.
Everything relies on it.
Everything hinges on that seal holding strong.
Which brings up a massive point of confusion I noticed in the post-op manuals.
The timeline.
Yeah, the timeline. A lot of these guides point out that by week 3 or 4, a patient might actually be feeling pretty fantastic.
Oh, for sure.
Their energy is returning. The external laparoscopic incisions are just, tiny faded scabs. So if you feel perfectly fine on the outside by week 3, what is happening on the inside that makes it so dangerous to resume normal activities?
Well, the surface healing is entirely deceiving.
Really?
Yeah, it completely masks a highly vulnerable internal state.
Yeah.
Because tissue repair doesn't happen all at once. It happens in these distinct chronological biological phases.
Okay, walk me through the phases.
So during weeks 1 and 2, your body is purely in damage control mode.
Just putting out the fire.
Exactly. It's rushing white blood cells to the cuff to decrease inflammation. It's essentially putting out the surgical fire.
So no actual structural reinforcement is happening yet?
Very little. Then as you move into weeks 3 and 4, the body finally begins laying down new scar tissue across that cuff.
Okay, so that's good, right?
It is. But we have to understand the physics of new scar tissue. It is incredibly fragile. It lacks what we call tensile strength, which is the ability to be stretched or put under pressure without tearing.
Ah, I see.
It takes a minimum of 8 to 12 full weeks for the cellular matrix of those internal structures to deeply knit together, mature, and reach a point where they can actually withstand normal physical forces.
12 weeks. That's 3 full months.
It is a long time.
So when the medical guidelines mandate pelvic rest, they aren't just giving a casual suggestion.
Right. Pelvic rest is a strict, non-negotiable medical directive for at least 4 to 6 weeks, and honestly, it frequently extends much longer, depending on how you heal.
And pelvic rest means?
It means absolutely nothing enters the vaginal canal. No tampons, no sexual intercourse, no medical instruments unless absolutely necessary.
But it's not just internal stuff, right?
No, it also includes strict limitations on your broader physical movements. Like, there's a hard limit on lifting anything over 10 to 15 pounds.
Because picking up a heavy box of groceries, that engages your core muscles.
Exactly.
And when your core flexes hard, it increases the intra-abdominal pressure, which pushes all your internal organs downward onto your pelvic floor.
You got it.
And that downward force stretches that delicate, newly sewn seam at the top of the sock.
The mechanical strain is immense.
Yeah.
I mean, even something as seemingly benign as straining from constipation can generate enough downward pressure to endanger the cuff.
Wow, really? Constipation?
Yes. The post-op manuals emphasize treating constipation aggressively with stool softeners for this exact reason.
That makes total sense now.
Because if that fragile seam is subjected to too much pressure before it achieves full tensile strength, you risk a catastrophic complication known as vaginal cuff dehiscence.
Dehiscence. That implies the tissue actually separates, like the seam rips open.
It does. It is statistically rare, occurring in less than 1% of hysterectomies, but it is a profound medical emergency.
I can't even imagine.
If the cuff tears completely open, the barrier to the abdominal cavity is just gone. And this introduces the risk of bowel evisceration.
Oh, no.
Yeah. The intestines can physically push through the ruptured cuff and descend into the vaginal canal.
Okay, that is a terrifying reality to visualize.
It's extreme, but it's the reality.
And it definitively answers the foundational part of our core question. The absolute minimum takeaway here is that you must wait until you are fully cleared by your surgeon.
Right.
And that clearance usually happens well past the 8 to 12-week mark, after a physical pelvic exam confirms the cuff is entirely sealed and structurally sound.
You cannot even entertain the thought of further vaginal procedures or intercourse until that baseline is met. Structural safety has to be the unquestioned priority.
So let's look at the psychology of this. If the healing timeline is so intense, requiring months of careful imitation just to avoid structural failure, why are women feeling this intense urgency to seek out vaginal tightening procedures afterward?
It's a great question.
If we pivot from the anatomy of the surgery to the physiological fallout, what is driving that desire?
Well, we have to look at the sudden systemic hormonal crash the body experiences.
The hormones.
Yeah. In many hysterectomies, particularly those treating cancers or severe widespread endometriosis, the surgeon removes the ovaries alongside the uterus.
And the ovaries are the body's primary manufacturing centers for estrogen.
Exactly.
So the factory is essentially demolished overnight.
The supply is instantly cut off, and this plunges the patient into what we call surgical menopause.
Which is different from natural menopause.
Very different. Natural menopause is a gradual tapering of hormones over several years, giving the body time to adjust. But surgical menopause is immediate and aggressive.
Wow.
That sudden sheer drop in estrogen triggers a widespread condition known as genitourinary syndrome of menopause, or GSM.
Let's unpack GSM for a second. What is estrogen actually doing for the vaginal tissues on a day-to-day cellular level when the factory is still running?
Estrogen is a vascular powerhouse. It maintains robust blood flow to the pelvic region.
Okay.
And that rich blood supply brings oxygen and nutrients that keep the mucosal tissues of the vagina plump, thick, highly elastic, and well lubricated.
So when you remove the estrogen,
The blood vessels constrict. The tissue becomes significantly thinner, it loses its elasticity, and the natural lubrication dries up almost entirely.
this leads to an incredibly fascinating paradox highlighted in our sources. Because the tissue is suddenly thin and lacks that crucial lubrication, women experience a profound loss of friction during intimacy. They feel this change, and they naturally interpret that sensation as vaginal laxity. They feel like things are too loose, which creates the immediate logical desire for a tightening procedure to fix it.
It's a completely understandable conclusion. I mean, anyone would think that. But it is often a structural misinterpretation.
A misinterpretation. Explain that.
The tissue hasn't necessarily stretched out like an old rubber band. It has just lost the plump, hydrated volume that previously provided that necessary friction.
Which means sometimes the issue post-hysterectomy isn't that the canal is too loose.
Right.
The reality is that the surgery and the hormone drop have actually made things too rigid or even too tight.
This is a vital distinction to make. Consider the mechanics of the surgery again. Creating the vaginal cuff requires pulling tissue together, which naturally shortens the vaginal canal slightly.
Oh, right. You're losing some length to make that seam.
Exactly. You then add the formation of new scar tissue, which is inherently stiff and inflexible.
Right, the scar tissue.
Combine that with the loss of estrogen, making the entire vaginal wall less pliable, and a significant number of women develop dyspareunia.
Dyspareunia, which is the clinical term for painful intercourse.
Yes.
Let's pause on that because the implications are huge. A patient might walk into a cosmetic clinic asking for a laser tightening procedure because she feels a lack of friction.
Yeah.
But structurally, medically, her tissues are rigid, scarred, and inflexible. She doesn't need tightening at all.
Not at all.
She actually needs the exact opposite. She needs stretching and rehabilitation.
And that scenario is precisely why conservative medical management must be the first line of defense. The clinical guidelines strongly advocate for pelvic floor rehabilitation before any surgical or cosmetic intervention is considered.
When I see pelvic floor rehab, my mind immediately goes to Kegel exercises. But aren't Kegels mostly prescribed to help with urinary incontinence?
They are highly effective for incontinence, but their utility goes much further. Yeah, contracting and releasing those muscles actively draws fresh blood flow into the pelvic region, which helps nourish that thinning tissue.
Bringing the blood back.
More importantly, it improves neuromuscular control. The trauma of surgery often causes the pelvic floor muscles to lock up in a chronic spasm, acting like a protective guard against pain.
Oh, like a defense mechanism.
Exactly. Physical therapy helps retrain the nervous system to release that chronic tension. Patients can typically start very gentle pelvic floor awareness breathing within a few weeks of surgery, but actual structured strengthening always waits until that 6-week clearance.
The sources also devote a lot of attention to vaginal dilators, mentioning brands like Intimate Rose. I want to understand the mechanism here. How does inserting a device solve the problem of rigid, painful tissue?
Well, vaginal dilators are smooth, tube-shaped, medical-grade devices, typically made of silicone, and they come in a series of gradually increasing sizes. Their function is deeply rooted in physical therapy principles. By gently inserting a dilator and maintaining steady pressure, you are physically stretching the shortened, inflexible tissues.
You're manually breaking down that rigid scar tissue we talked about.
Mechanically, yes.
Yeah.
But neurologically, you're also utilizing something called the gate control theory of pain.
The gate control theory, what's that?
The steady, predictable pressure of the dilator sends safe sensory signals to the brain, which essentially override and calm the hypersensitive pain receptors in the area.
Oh, wow.
It trains the localized nervous system to stop treating expansion as a threat, which directly treats the painful tightness of dyspareunia.
So the overarching lesson of this first phase of our deep dive is clear. If you are experiencing discomfort, a loss of sensation, or a feeling of laxity after your 12-week recovery, your first appointment shouldn't be at a cosmetic laser clinic.
Absolutely not.
It needs to be with a pelvic floor physical therapist and your gynecologist to address the functional mechanics and hormonal realities of your body first.
The foundational health of the tissue has to be restored before you ask it to endure anything else.
Let's play out the alternative scenario, though.
Okay.
Let's say a listener has done everything right. They're 8 months post-op, the cuff is perfectly healed, they've done months of pelvic physical therapy, their estrogen levels are optimized with localized creams, but true structural vaginal laxity remains a persistent issue that is deeply impacting their quality of life.
It happens.
At that point, what are the actual tightening interventions available?
At that stage, the medical landscape splits into two distinct pathways. You've got surgical interventions and non-surgical interventions.
Surgical tightening sounds incredibly daunting for someone who just spent 3 months recovering from an organ removal.
Right.
What does that actually entail?
It is a major undertaking. Surgical tightening typically refers to procedures like a posterior repair or a formal vaginoplasty.
Okay.
The surgeon makes an incision and literally dissects the vaginal mucosal lining away from the underlying tissues near the rectum.
Oh, wow.
Yeah, they locate the separated or weakened muscles, pull them tightly back together with sutures to restore structural support, trim away any excess stretched mucosa, and stitch the lining back up.
That is highly invasive.
Very. It requires anesthesia, significant surgical skill, and it introduces all the associated risks of surgery, including infection and bleeding.
And the recovery.
Most notably, it requires another 4 to 6 weeks of strict, painful recovery. You're essentially resetting the biological healing clock back to zero.
Which perfectly explains why the secondary pathway, the non-surgical energy devices, has absolutely exploded into a multi-million-dollar cosmetic industry.
Oh, completely.
Women here, they can bypass another 6 weeks of pain. The sources focus heavily on these energy devices, so how do they work?
The cosmetic gynecology sector relies heavily on 2 types of technology. The first is fractional CO2 lasers, with common brand names like Mona Lisa Touch or Noviva.
Yeah.
They also utilize erbium.YAG lasers, such as the Photona system. And then the second distinct technology relies on radiofrequency, or RF devices like Introgen.
I want to focus on the CO2 lasers first, because the phrase lasering your sensitive tissues sounds alarming.
It sounds intense, yeah.
To understand the physics, think about a landscaping technique. Aerating a lawn.
Well, it's interesting.
When the soil in your yard becomes completely compacted and the grass starts dying, you don't just water it, you run an aerator over it, which violently punches thousands of tiny, deep holes into the dirt.
Right.
That physical trauma forces the grass roots to grow deeper to survive, and it opens channels for water and nutrients, resulting in a lawn that grows back vastly thicker and stronger.
That is a phenomenal analogy for the mechanism of fractional laser therapy.
Really?
Yeah. A specialized laser probe is inserted into the vaginal canal. It doesn't burn the entire surface area. Instead, it pulses beams of light energy to create a grid of microscopic thermal injuries deep into the mucosal layer.
So it is intentionally inflicting damage on the tissue.
It relies entirely on controlled damage. The goal is to trick the body's natural healing cascade into activating. When the tissue detects these microburns, it signals fibroblasts, which are essentially the construction worker cells of your biological matrix, to flood the area.
Okay, the construction workers arrive.
Exactly. These fibroblasts kick into absolute overdrive, manufacturing massive amounts of new collagen and elastin, the proteins that give tissue its structural bounce and firmness.
And what about the radiofrequency devices? Is that just a different type of laser?
No, it's a completely different mechanism of physics. Radiofrequency does not use light energy to burn holes.
Oh, okay.
Instead, it uses electromagnetic waves to safely pass through the surface layer of the skin and heat the much deeper dermal layers.
Like how a microwave heats the inside of food without burning the outside?
Very similar, yes. That deep targeted heat causes the existing collagen fibers to instantly contract and tighten, providing an immediate firming effect.
Ah, I see.
Simultaneously, the thermal stress triggers that same long-term fibroblast response, building new collagen over the following months without creating open microwounds on the surface.
Looking at the logistical data in our sources, the appeal of these non-surgical routes is obvious.
They sound great on paper.
These procedures are outpatient. A session takes about 30 minutes, you don't need general anesthesia, and the downtime is incredibly minimal. I mean, patients are usually just advised to abstain from intercourse for maybe 3 to 7 days while the immediate inflammation subsides.
Right. The standard protocol generally involves a series of 1 to 4 sessions, spaced carefully about 30 to 45 days apart.
Why the wait?
That waiting period is crucial because it takes time for the body to actually synthesize and remodel the new collagen.
Okay, that makes sense.
And efficacy is often measured by clinics using something called the Vaginal Health Index, which grades the tissue on a 1 to 5 scale based on elasticity, fluid volume, pH balance, epithelial integrity, and overall moisture.
It sounds incredibly convenient. It's marketed as a modern, high-tech quick fix, but we need to introduce a serious reality check here.
We really do.
If these energy devices are so heavily promoted and seemingly so simple, how does the broader established medical community view them? Are they embracing the technology?
This is where we uncover a massive, glaring divergence between cosmetic clinic marketing and official evidence-based medical consensus. When we review the guidelines from major authorities like NICE in the UK, their directives are crystal clear. They specifically state that they do not recommend the routine use of vaginal lasers or radiofrequency devices for the treatment of vaginal laxity.
They explicitly advise against it as a standard treatment.
They do. Their first-line recommendation always remains pelvic floor rehabilitation and localized hormone therapy.
Wow.
We see the exact same stance from NHS Greater Glasgow and Clyde, which explicitly categorizes female genital cosmetic surgery and related energy treatments as medically non-essential. They refuse to offer it for cosmetic-only reasons.
This makes me wonder about the stakes. If the official medical guidelines are aggressively pumping the brakes on this technology, what are the actual physiological risks?
They are very real.
I have to assume their hesitation isn't just because the lasers might be ineffective. It's because they have the potential to actively cause harm to the patient.
The potential for harm is significant and well documented. While many small clinic-funded studies report high patient satisfaction, the FDA has been forced to issue stark warnings regarding the use of energy-based devices for vaginal rejuvenation.
The FDA stepped in.
Yes. When researchers analyzed the adverse events reported to the FDA's MAUDE database, a very dark picture emerges.
What kind of complications are women reporting?
In an analysis of 45 specific patient reports detailed in our sources, women suffered from severe chronic burning sensations, permanent numbness, worsening of their urinary incontinence, and severe dyspareunia.
Wait, really?
Meaning the laser procedure actively caused the very agonizing, painful intercourse it is so frequently marketed to treat.
There is one specific case report in our stack of sources that is genuinely chilling. It perfectly illustrates the hidden dangers of treating the body like a cosmetic playground.
The case of the 52-year-old patient.
Yes. She was experiencing what she perceived as mild vaginal laxity and a slight internal bulge.
Right, and she opted for the seemingly easy route. She underwent vaginal laser treatment, hoping to tighten the tissue and resolve the bulge without surgery.
But the laser failed to improve her symptoms. So a full year later, she finally decides to undergo the actual invasive surgical posterior repair we discussed earlier.
But the laser had fundamentally compromised her anatomy.
How so?
When the surgeon opened her up to perform the repair, they discovered that the mucosal lining was no longer healthy, separate, pliable tissue. The laser energy had effectively cooked the cellular matrix, resulting in severe, widespread fibrosis.
Fibrosis meaning thick, rigid, chaotic scar tissue.
Exactly. The scarring was so profound that the natural planes of tissue had fused together. It was incredibly difficult for the surgeon to safely dissect the vaginal mucosa away from the underlying structures without causing further damage.
That's awful.
The quick fix, laser treatments severely, dangerously complicated the standard medically necessary surgery she eventually required.
That is a staggering reality check. It is absolute proof that just because a procedure is labeled non-surgical does not mean it is non-consequential.
Definitely not.
You are fundamentally, permanently altering the cellular architecture of your body. When you have just spent 3 arduous months letting your body carefully, miraculously stitch a vaginal cuff together after removing an organ, introducing deliberate thermal burns to that exact delicate area is a monumental risk.
It demands serious, sober consultation with your primary gynecologist, not just a consultation with a cosmetic med spa trying to sell a package of laser sessions.
The biological stakes are simply too high to base decisions on marketing materials.
100%.
So let's bring all of this vast medical, physiological, and anatomical data back to the core mission of this deep dive. You have undergone a hysterectomy. Your body is doing the heavy lifting of internal reconstruction. And you are asking, how long after a hysterectomy should I wait before vaginal tightening?
The uncompromising medical baseline is that you must wait an absolute minimum of 8 to 12 weeks until your surgeon has conducted a physical exam and definitively confirmed your vaginal cuff is perfectly structurally healed.
But the deeper, more important answer synthesized from all our medical sources is that you need to pause and seriously investigate whether tightening is actually what your body requires.
Right.
The profound drop in estrogen and the rigid trauma of surgery frequently create a deceptive sensation of laxity when the actual underlying medical issues are severe dryness, tissue rigidity, or muscular pelvic floor dysfunction.
Your initial, most effective interventions should always be focused on estrogen management to restore blood flow, pelvic floor physical therapy to release muscle spasms, and potentially dilator therapy to retrain the nervous system's pain response.
Give the physical therapy and the tissue rehabilitation time to work before you ever let a laser near that healing tissue.
Absolutely. And that brings up a broader final thought I want to leave you with, which is drawn directly from the NHS Right Decisions source material.
Oh, this is fascinating.
They cite a deeply revealing study suggesting that up to 40% of patients cannot correctly identify their own genital structures.
40%. Nearly half of the patients seeking care do not possess a baseline understanding of what a normal, healthy vulva or vagina actually looks or feels like.
It is a stunning knowledge gap. And we must recognize that we live in a culture that relentlessly markets an idealized, often mathematically symmetrical, prepubescent aesthetic for women's bodies.
We're constantly sold the narrative that tighter is inherently better, and that any anatomical change is a dysfunction that requires a purchased cosmetic fix.
It is an immense, heavy societal pressure to place on someone who is just trying to navigate life after a major surgery.
It really is.
It forces us to ask a difficult question. How much of the booming desire for cosmetic gynecology is driven by actual, functional medical necessity?
Right.
And how much of it is driven by a fundamental, culturally induced misunderstanding of what a healthy, normal human body looks and feels like as it ages, as it experiences massive hormonal shifts, and as it brilliantly, miraculously recovers from the trauma of major organ removal?
That is an incredibly profound concept. It is something vital to chew on the next time you scroll past an advertisement promising a 30-minute laser quick fix. The human body is the ultimate reconstruction site.
It really is.
It possesses an ancient cellular knowledge of how to heal itself, but it demands patience and absolutely requires respect for the biological process. Give your body the time to finish pouring the foundation before you start worrying about the interior decorating. Thank you for joining us on this deep dive. Keep questioning the narratives around you and keep learning.